first speaker is Professor Sue Hignett. Sue is the Chair of Ergonomics and Patient Safety at Loughborough University in the UK. And I think I'm right in saying that she was centrally involved in getting the Chartered Institute of Ergonomics and Human Factors its Royal Seal. Sue is going to talk today about the scope of human factors and also how they've managed a range of issues in the UK in their first wave. Thanks very much, Sue.
Thank you for inviting me to present at this Monash University webinar. I'm very pleased to be able to share my experience from the first wave of COVID-19. I want to start off though just by getting everybody onto the same page, and I apologise if you know all of this already and I'm teaching grandmothers to suck eggs, so please forgive me if that's the case. But if not, and you're fairly new to human factors ergonomics, I just want to set the scene. So as a discipline, we are an international collaboration, and we have an international overarching body called the International Ergonomics Association. You'll find that the terms human factors and ergonomics are used interchangeably. Tends to be more human factors in English-speaking countries, and you'll find that most other countries that aren't English-speaking, it'll be ergonomics. So we all have agreed this definition at the IEA in 2000, and we all work under that umbrella. So we are a scientific discipline, and we're also a profession. As a discipline, we're concerned, our focus is looking at the interactions of humans and other elements in the system, and then as a profession we apply that knowledge. And our fundamental purpose is about designing, changing things to optimise human well-being and overall system performance. And in the UK, our professional body here is the Chartered Institute of Ergonomics and Human Factors. So the two projects that I'm going to talk about today all happened earlier this year in April, March, April, May, June, and it's about provision of ventilators with the concern that there wouldn't be enough ventilators available, and then an opportunistic survey that we undertook to find out about how staff, how clinicians were coping with working in the extra layers of PPE. So when the government in the UK announced that they were going to put out a call for manufacturers to produce ventilators to increase the stock, this went very widely to lots of manufacturers, obviously, who weren't used to working in healthcare. And we were really concerned. And we put this information out that we were worried in the public domain, and which was picked up by our local media. So this was actually one of our national broadsheets covered this and said why we were worried about it. And the reasons that we were worried about it was because if a manufacturer is not used to designing equipment in the health and social care domain, they probably don't have an understanding of these four human factors issues. They may not understand the users, the range of users, the different professional groups who may be interacting and working with these ventilators. They may not understand the environment of use, and this is particularly important in COVID because, as you know, new ICUs, there were pop-up ICUs with theatres being repurposed and even new hospitals being built, Nightingale hospitals in the UK, for example. They need a really good understanding of the task, what is being done, how many different tasks might be done using this equipment, and therefore what are the risks that might incur as part of that use. Using these four human factors principles, they then should be able to design a good user interface. If you get the design right and make it intuitive by understanding the user requirements, then there should be less of a reliance on instructions for use or training. This really is our principle. If you get the design right, then humans will just intuitively be able to do the right thing. You'll need a certain amount of training, obviously, as you would for any new piece of equipment. But the better the user interface design is, then the safer and the more effectively the equipment is likely to be used. So the sorts of issues that we included within this guide, which is freely available on the Chartered Institute website, is that if you can, base the new design on existing designs, because then people will be able to carry over that knowledge for a new medical device, which would be great. The user interface should be intuitive, it should provide feedback. Obviously there'll be alarms, but the alarms should be only for critical situations, and also they need to be relevant to the environment. So what's the ambient noise level like? We need to make sure that the physical side of it, the connectors, the cables, all are not going to get in the way and are going to work. Things like the screens and displays can be adjusted, and for example the buttons, the way they're set out on the control panel, can you follow it? Are they where you expect them to be? And have they been designed so that you don't accidentally press 2 at the same time? Now, in order to produce a medical device, you actually have to do a formative usability test as part of the ISO standard. And because a lot of these manufacturers were not used to working in healthcare, they didn't have the knowledge to develop a formative usability test, and they only had 24 hours for this testing process. So we said, okay, we can provide the protocol for you for this test. So we worked with a large range of clinicians to develop this formative usability test, and I'm just going to talk about 2 aspects of it. So the first aspect is thinking about the different tasks. So the ventilator design has to work for frequently occurring tasks, safety critical tasks, tasks where novice users or people might have come back from retirement or whatever may make mistakes, and tasks where there are known to be problems. So we trawled through the literature and found out where there were known problems with ventilators. And then obviously tasks about moving ventilators around. One of the core human factors principle methods that we use to do this is hierarchical task analysis. And this is where we had over 100 volunteers within the Chartered Institute, from clinicians to chartered members to a wide range of engineers and psychologists who wanted to support this initiative. And the HTA for this project was developed by David Embry and his team at Human Reliability Associates. And they normally work in the oil and gas and the nuclear industry, but they are very, very experienced at HTA and unpacking complex activities, and this was perfect for ventilator use. And you can see that it goes into detail, and this is what designers need to know for what needs to be in that ventilator and how they're going to ventilator interface design and how it's going to be used. So the next thing in the formative usability test is a scenario, actually doing the test. And for this we worked with clinicians, anaesthetists, to put together, you need a test which basically covers a lot of activities you wouldn't normally get within a very short time frame. But when you're running a test like this, you have to basically push the interface to its extremes so that you try and identify where errors could occur and basically give it a hard time. So the test has to be really quite inclusive of a range of things, the different ways it could be used. And this has all been published now. It's gone into an open access journal. You can see we had a lot of people working on this, also from our regulatory investigation branch, HSIB. So we had a real team co-development here to produce this. And we were also working with the Intensive Care Society and the Faculty of Intensive Care Medicine, who reviewed input and helped develop these guidance and the formative usability protocol. So along with these 2, the ventilator guides, we also produced a ventilator emergency bedside guide for using it, and this was developed with the Nightingale Hospital in London. We produced guidance on how to produce procedures, and that's obviously got a much wider application than COVID. But if you're going about producing procedures, particularly in this time where we've got different staff working together, I think that's a really valuable document to have a look at. And then finally, we also produced a guide on routine tracheostomy care. So I'm going to move on to the second project. And as I said, this was an opportunistic survey. My colleague, Professor Jay Banerjee, who works in Leicester in the emergency department there, almost immediately, we went into lockdown in the UK on the 23rd of March this year. And Jay was in touch almost immediately and said, all this PPE is changing the way I work. If it's changing the way I work, for me, it's going to be changing it for other people too. He said, let's find out about it. So we very quickly put a survey together and got it out. During the time period we had the survey open, we had over 33,000 excess deaths in the UK and over 300 health and social care staff now. Unfortunately, that's now over 600. And this short survey has been published in the Anaesthesia Journal as a short report. So what did we ask about? Well, we asked about face cover, body cover and gloves. And the human factors ergonomics issues that we're interested in was, do things fit? Are they comfortable? Can you do what you need to do for your job? Can you read? Can you operate equipment? Can you hear? Can you communicate with each other and with your patients? Can you reach? Can you touch things when you're moving around? And how is your dexterity changed? Whether that's for touch screens or buttons or opening vials, whatever. So we had over 400 responses, which we were very pleased about, given that how everybody was just nose to the grindstone at that time. And the distribution, 72% women, 28% men, is actually fairly representative of the demographic in healthcare. And analysing the results, the responses that we got, we came up with 4 main categories: wearing PPE, working in PPE, surviving PPE, and supplying PPE. So wearing PPE, we actually did analyse, we disaggregated the data for sex, and we did find that women didn't fit the PPE as well as men, which is no great surprise, but that's from an empirical data analysis. When we look at working in PPE, the sorts of issues that came up were putting it on, taking it off, how your vision was changed, how your dexterity was changed, and the duration of wear, and we'll pick that up a little bit in surviving PPE as well. But the issues around that were, how wearing the mask could actually change your ability to see. One of the big problems was wearing goggles, safety goggles over prescription glasses. A lot of problems reported with that. So when we look at surviving PPE, and there were some pretty horrific images which were tweeted of people having pressure area sores and abrasions and problems over the ears, as well as around the mask fit. So the sort of contact interface, but then also the duration of wear, that you overheat, that you dehydrate, and we heard of people not wanting to come out of a red zone because it takes so long to doff and then re-don to go back in, and so they weren't drinking enough. So problems with that too, which then obviously affect your concentration and contribute to fatigue. So supplying PPE, we weren't looking at the numbers supplied. We were more interested in the differences in makes and models. Typically in the UK, people were fit tested for probably 2 makes, and yet what we heard was that there could be 6 different makes in a hospital, so you could go on a shift and there wouldn't be a mask that you've been fit tested for. So I just want to finish up by giving a big thank you to the Chartered Institute. Our Chief Executive Officer, Norman Rashid, led us on the Gold team in the first wave. And we are now, as I say, working to push patient safety and get some of these fundamental principles embedded throughout our health and social care. Thanks very much.